My name is David Denning. I'm a Professor of Infectious Diseases and Global Health at the University of Manchester and President of the Global Action Fund for Fungal Infections. Over 300 million people are affected by serious fungal diseases worldwide, and 25 million of them have life-threatening or hugely debilitating illness. If you compare the death rates from fungal diseases with those of malaria and tuberculosis, you'll see that they're of the same order of magnitude, just a little less than 1.5 million each year. Our vision is to greatly reduce illness and death associated with fungal diseases worldwide. We're going to do this through four overarching goals. The first is to measure the impact of fungal infections worldwide. The second is to ensure, if we can, universal access to diagnostic testing and also antifungal treatments all over the world. And in order to make sure that these tests and treatments are used appropriately, we need to educate healthcare professionals. If you look at AIDS specifically, there are 1.7 million deaths from AIDS in 2011. And of those, about a quarter died from tuberculosis, which is clearly a major issue, but 3/4 died of numerous other infections, of which fungal diseases are a major contributor. One of these is cryptococcal meningitis. This is a brain infection leading to vomiting and headache and then unconsciousness. And pneumocystis pneumonia is another. This is a very severe pneumonia which leads to shortage of oxygen and breathlessness, and patients die essentially from lack of oxygen. Another of the areas of priority for us in GAFFI is fungal keratitis. This is related to injury, and patients get a fungal infection in the cornea of the eye, and it progresses without diagnosis or treatment to lead to blindness. In fact, in India, about 10% of the patients with blindness have had keratitis, and in Ugandan children, about a quarter of them are blind because of keratitis in the eye. Another area of the focus of GAFFI is in fungal asthma. I hear a number of reports from all over the world, the Mayo Clinic, the BBC News from Puerto Rico and from Scotland, indicating the power of fungus to really exacerbate asthma in a big way. But if you look at the studies that have been done, there have only been 6 studies done on this in terms of how frequent this problem is in the last 35 years, compared with hundreds of studies done with tuberculosis, malaria and bacterial infections. So the focus of our work at GAFFI is on cryptococcal meningitis in AIDS, of which there are thought to be 1 million cases worldwide and an estimated 600,000 deaths. Pneumocystis pneumonia, which there are over 400,000 infections worldwide and at least 80,000 deaths. Fungal keratitis, which leads to blindness in about 1 million people and possibly as many as 12 million people, particularly a problem in Southeast Asia. And fungal asthma, which affects primarily adults with asthma, of whom 20 million have severe asthma, and there are 350,000 asthma deaths each year, almost all of these in adults. Now, with cryptococcal meningitis, this diagnosis is readily achievable with really an excellent, simple antigen test, which takes 10 minutes, costs $2, and is available in many countries of the world. And if you can make the diagnosis, then treatment with fluconazole, which is available in many countries, has a 50% response rate. But there's a better treatment with IV therapy with amphotericin and 5-FC, which gives a 75% response rate. And if you compare the efficiency of that and the costs of that, it costs an extra $300 in current prices to get a much better outcome for cryptococcal meningitis. That's money well spent, in my view. And unfortunately, flucytosine, which is one component of that best therapy, is not available in large parts of the world where we really do need it. Sub-Saharan Africa, Southeast Asia in particular. Pneumocystis pneumonia, as I've indicated, affects at least 400,000 worldwide. It's a human-only pathogen. The microscopy, which is not really available in much of Africa, is only 75% successful in terms of making a diagnosis, but a molecular test is a much better test and is at 98% sensitive. Unfortunately, these tests are not available throughout much of Africa and certainly in many other parts of the world, low-resource environments. And yet, if you can make the diagnosis, the treatment is 85% effective. And if you don't make the diagnosis and the patient isn't treated, all these patients die. Fungal keratitis is an injury-related illness, particularly in farmers and those working in manual environments. It's difficult diagnosis to make because you need an ophthalmologist, you need a very good laboratory, and so it's a tough diagnosis, and therefore we need to develop a much better test, a much simpler test for this infection. If we can do this, we can avert some of the terrible outcomes from fungal keratitis, illustrated by this work from Tanzania, where 66% of the patients ended up blind in the eye and 8% had to have their eye removed. These are bad outcomes, and we need to change this. The treatment is pretty effective. If you have really severe disease, it's 60% effective. With milder disease, 75% effective. So we need to make this treatment available to all those with fungal keratitis around the world, and we need to make it affordable. Fungal asthma, I've indicated, is a big deal. To take the UK as an example, there are 70,000 admissions in the UK each year, and at least half these patients are sensitized to fungi. And antifungal therapy is really very effective for these patients. 60 to 80% improve with antifungal therapy. And in many of these patients, their health is completely transformed. They're able to stop their steroids, their asthma attacks recede, and they don't come into hospital for any care. So as I've indicated, diagnosis is critical to improving the outcome of these patients. So cryptococcal antigen testing, simplification of the pneumocystis PCR, molecular testing, antibody testing for aspergillosis, histoplasma antigen testing, and tests for fungal keratitis, and allergy skin testing for patients with asthma. Our immediate goals in GAFFI are to assess how common these infections are in each country, to demonstrate the benefits of diagnosis and treatment for our priority diseases, to develop simpler diagnostics and standardize what we already have, to encourage advocacy at the highest levels in global health and WHO and UNAIDS and other international agencies, but also in country, because it's important that within countries people understand the significance and importance of managing fungal disease appropriately. And this needs to proceed through our healthcare professionals all over the world. What we're trying to achieve is major falls in the current death rate from fungal diseases worldwide. We hope to bring this down by half, if we possibly can, by implementation of all of these areas. We want big improvements for health for those with chronic fungal infections as well, particularly asthma and patients with chronic fungal and lung infections and skin infections. And we want simpler, cheaper diagnostics and simpler, cheaper antifungal drugs if we can get them. And we also need, and there will be benefits for medical practice across the spectrum of all of the underlying diseases which patients with fungal disease get, because there will be better care, because there will be greater understanding for these patients who really do at the moment suffer, and because there's not enough attention and not enough knowledge and not enough precision diagnostics available for their care. The GAFFI website is available online at www.gaffi.org, and on that there's a lot of additional information, and in particular some fact sheets about our priority diseases, which may be helpful to you. Can we count on your support in taking GAFFI forward? Many thanks for your attention.